Welcome to RegenMed Global, the podcast. Today, we're here to discuss a new disease-modifying drug for Alzheimer's that is currently pending review from the FDA. This drug is called Donanemab. With us, we have principal investigator of this study, Dr. Julio Rojas, associate professor of neurology at UCSF. Dr. Rojas, it's a pleasure to have you. Thank you for joining.
Cheyenne, thank you for having me. It's a pleasure to be here. And just to clarify, I'm a site principal investigator. I'm not the principal investigator of the whole study, which is this drug has been studied through industry-sponsored research. So I'm a local PI or principal investigator for the UCSF site here in San Francisco.
Okay, great. Thank you for the clarification, doctor. Before we get started, can you tell us a little bit about kind of what you do in your background?
Yeah, so I'm a behavioral neurologist. I'm specialized in dementia care and research, and my passion really is on developing new treatments for these neurodegenerative diseases, the most common one being Alzheimer's disease. But it's not all about drugs. A lot of the care also has to do with helping people with the day-to-day problems, connecting people with resources, especially caregivers, to feel them or make them feel empowered and in control. And the goal in these chronic conditions is to help people have the best day-to-day and stay safe. And if we can find ways to slow down the disease or treat the symptoms with medications, that's also great. So that's mostly what we do, or what I do as part of my academic work here in UCSF.
Okay, great. I mean, with you being involved with this new disease-modifying drug for Alzheimer's, can you tell us a little bit about how Donanamab works?
Absolutely. Donanemab is part of a family of drugs that we call third-generation anti-amyloid therapies. All these therapies, what they have in common is that they are monoclonal antibodies that are designed to bind to a junk protein that accumulates in the brain called amyloid. The hypothesis is that amyloid appears in the brain and triggers a cascade of events that eventually lead to cell death, neuronal loss. And with neuronal loss, we don't have the substrate, or people don't have the substrate to maintain cognitive function, so people start having memory problems or executive problems, and that affects autonomy or independence. So what these drugs do is they bind to amyloid and help the body clear amyloid from the brain. And what we've seen in the trials is that these drugs are really good at clearing amyloid from the brain. Basically, is what I call the Rogan commercial effect, the before and after, right? If you treat someone with one of these drugs for a year and a half with an infusion that goes through the vein every month, by the end of that period, amyloid can be almost completely removed, or removed by the naked eye, basically. We see it in a scan. And the big question, we know they're effective at doing that, removing amyloid. The big question has been, how much of that removal comes with a benefit for the person? How much are we slowing down? And what we have learned through these studies is that, yes, these drugs are not the most potent drugs in terms of slowing down disease, but they are having an effect. Maybe they have 25% or 30% efficacy at slowing down the disease. What we want is a drug that is 100%, but this is the discovery of these drugs, I think, is a step in the right direction.
Can you give us an overview of how these clinical trials have been conducted for studying the effectiveness of this drug?
The pipeline is the same pipeline that we use in every field of medicine, where there are different stages of development for all the drugs. So there are clinical trials. So clinical trial is basically an experiment where we give a participant a drug and we see the effects. The first stages of any drug development start with making sure that the drug is safe. So in a phase 1 trial, the main goal is to test the safety and the safety and tolerability of a drug. And then phase 2, that is done in the same way we test the tolerability and safety in a larger scale, maybe a group of 100 to 200 patients or participants. And if we are convinced of the safety, then all these drugs go to phase 3 trials, where the main goal is not to test tolerability or safety, but to test efficacy. So Donanamab went through that process. And there was a big clinical trial, phase 3, that provided the best evidence that we have of its efficacy. And this is what has created the path for approval and hopefully widespread availability for physicians to use and offer to their patients.
What kind of results have we been able to conclude from the major recent clinical trials and just from the major findings?
Yeah, the main finding of the latest study, and the information was published or was shared with the scientific community in the last Alzheimer Association International Conference in July, and it was published at the same time in a major scientific journal. What we know from that study is that, number one, yes, treatment with Donanemab is associated with significant removal of amyloid, and that amyloid is accompanied by a slowing down of disease progression. The disease progression is measured with a standardized scale that includes not only cognition but also function and independence. What I care about most, and most of us, what we care, and my patients mostly, what they care about is autonomy and independence. So these scales that are being used in these new clinical trials have a big component of measuring function. And then the third aspect of this is that these effects of amyloid and cognitive function are also reflected in other markers that are objective markers, for example, blood markers of degeneration. So again, these drugs are not 100% potent, but there is a believable effect. There's a big difference between people who get the drug and people who get placebo. People who get placebo continue declining at the expected rate. The expected rate. And then another very interesting observation is from this late Donanemab study is that it's very likely that if we offer the drug in earlier stages of the disease, the effect might be even more dramatic. For example, when the drug was given to people with mild cognitive impairment, not people with established dementia, but with mild cognitive impairment, people tended to respond better. The earlier the stage, the better you respond. To the point that the slowing down in those people with mild cognitive impairment was in the magnitude of maybe 60% slowing down in the rate, as opposed to people with mild dementia where the effect was maybe 30%. So just to give you an idea, so the hypothesis is, or the signal is, if we treat people earlier, we might be able to have even a larger effect. So this was a major finding of this study as well.
Can you tell us about what percentage of change there was in terms of disease progression, how much it slowed down?
That's a great question, because this has been a point of debate, right? I mentioned that to measure progression, we use these standardized scales that measure cognition and function, right? Mm-hmm. So if you look at the change in terms of the number of points that you lose or gain in the actual scale, the change is very low in magnitude, right? That people might even question, is that significant? For example, if I have Alzheimer's disease and in a year and a half I'm expected to go from let's say 0.5 of severity to 1.5 or 2, is that significant, right? And some people may argue that is such a small change that even though comparatively with the people with placebo is 30%, in terms of points, in terms of the actual benefit, The absolute benefit, it might not be too much, but I will argue that, especially in early stages, going from zero point 0.5 to 2, it makes a big difference because it reflects progression from mild cognitive impairment to mild dementia, which has a lot of implications. The main implication is mild cognitive impairment people still have some autonomy. They need accommodation, but they can still operate in an autonomous way. But when you cross over to dementia, that means you are not independent for some things, and that has medical legal implications. For example, in the state of California, that means you might not be able to drive anymore, right? So this can have large implications, even though at the point level you may see is not a lot. So this has created a lot of debate, and I think a lot of the resistance to go and to embrace the data is based on this, that maybe at the point level the effect is not very strong, but we are convincing ourselves when we see more and more data emerge, because again, this is not the only trial that has demonstrated. The other drugs that are part of this new family of third generation anti-amyloid therapies show exactly the same trends and the same strength in the effect. So that's very important to consider. And again, this will be as a building block, a first step to hopefully discover more potent drugs, safer drugs as well. When we can talk about the side effects, this is something that I think people should know. It's important that whoever is considering getting these drugs also are aware of the potential side effects. But
yeah, let's actually talk about kind of the risk right now.
Yeah, well, bluntly, I can tell you the main thing of these drugs is that they cause brain bleeding and brain swelling, and that may sound very shocking, right? To have brain bleeding and brain swelling. Most of these people who develop brain bleeding or brain swelling, which is about 40% of people who get the drug, who got Donanemab, for example. So 40% is almost half of people, right? Yeah. In a year and a half. Most of those people, so let's say 80% of those 40%, most of them don't have any symptoms. And we only know that people are developing these side effects because we are closely tracking them with serial MRIs. So we repeat brain MRIs to take a look at what the effects are. Not only looking at the cognitive function and independence in terms of efficacy, but also monitoring the potential bad effects. So a fraction of people have symptoms. The most common symptoms are a headache, confusion, or transient, what we call focal deficits, which could be, for example, not being able to see or having difficulties moving one part of your body. But what we've seen and we've learned now with repeated studies is that most of these effects are transient, and we can mitigate the effects by withholding the drug for 1, 2, 3 months until we see that the changes resolve in the brain, and then we can resume the treatments. It's very important that people who will get Donanemab or any of these drugs are willing and able to get an MRI too, or serial MRIs. If you're not able to undergo an MRI for whatever reason, it could be claustrophobia, or you have a piece of metal in your body that is incompatible with a brain MRI, then you might not be a good candidate to take this drug. So the close monitoring with brain MRIs is key to use these drugs safely. So yeah, those are the main side effects. And of course, every time you have a medication, you have a risk of an allergic reaction, which also has happened with these drugs, but not at an unexpected rate. This is at the rate that we will expect with any drug. And this can be, again, managed safely with the right medications and with the right precautions. So what we have learned is that we can use, even though the side effects are there, we can use this drug safely. And when you put everything on a balance, the benefits seem to outweigh the risk, especially when the drugs are used in expert or by expert hands.
Are there still studies going on with the phase 3 trial or phase 2 trials? Or is
Phase
that
three
completely
trials,
different?
yeah, absolutely. I mean, this is a very important thing that I'm very interested in people knowing and learning about. I mentioned before that one of the observations of the Donanemab study was that it seems that people who get the drug in the earlier stages of the symptomatic stage, in mild cognitive impairment stage, seem to get the major benefit. So the leadership of these studies and a lot of experts in the field have posed the idea that the benefit of this type of drugs would be even higher if we could deliver the drug or offer the drug to those people that have not even developed symptoms yet. So if we could have a way to detect who is at risk of developing symptoms, and if we give them the drug before symptoms start, then the magnitude of the effect will be. Because all these trials that we are talking about have offered the drug to people with symptoms, to people with a diagnosis, at least of mild cognitive impairment. But what would happen if we offered the drug to people with absolute cognitive health, no memory problems whatsoever? What if we could catch them 3, 4, 5 years before they may develop symptoms? So there is such a thing. There is a study called AHEAD, kind of like think of getting ahead of the disease, right? That is doing exactly that. It's using a drug similar to Donanemab, part of this new generation of drugs that target amyloid. And we are identifying those people at risk of progressing to having cognitive symptoms. And we are offering the drug in a clinical trial setting, phase 3 clinical trial setting, before the symptoms start. It's an experiment. So you have if you enroll in the trial, you have 50% chance of getting the drug and 50% chance of getting the placebo. The drug is given through the vein on twice a month, every 15 days for 4 years and a half. It's a long study, but this is the only way we know we can make an impact on the disease, right? So these are such innovative trials because for the first time we're trying to prevent the disease before it starts, and we are taking advantage of all this information that we have learned from studies in people with symptoms. So these are radical trials. So I invite everybody who is interested in learning about this trial. aheadstudy.org is the site. It's a partnership between the National Institutes of Health and industry, and this has shown to be a very productive way of finding drugs. Which this partnership between federal money and industry money, and that implies that the leaders in the field are involved. The leaders of thought, people who have been studying the disease for so many years, are involved in designing the study, conducting the study, making sure that it's safe, making sure that it has the best scientific rationale. And we are enrolling nationwide. So everywhere in the U.S., we have centers, mostly academic centers, but also private infusion centers are enrolling people. And from the perspective of the patient, is empowering people to act upon something before it even starts. I can tell you very quickly who is qualified to participate. People with no symptoms, cognitive health, who are 55 years old or older, and are interested in this type of study. So if they want to participate, aheadstudy.org is an important resource. And I feel there might be new studies with this type of drugs. There might be new opportunities that we will see in the next few years. So clinical trials continue because I don't think we are at the end of the road. We are at the beginning of the road in discovering these new drugs.
Now with Donanemab, can you tell us how that procedure would look? Let's say it gets, because right now it's pending FDA approval, right? Let's say if it gets approved, it's available for patients. How would that look like in a clinical kind of environment?
Yeah, the first thing that will happen for everybody interested is you need a diagnosis of cognitive impairment that is suspected to be due to Alzheimer's disease. And that has to be with the features of the symptoms. For example, the memory loss is very important, but not necessarily. So it's very important that people have an evaluation by a specialist, a neurologist specialized in dealing with dementia. The first step of that evaluation is to confirm that Alzheimer's disease may be in the picture, and that can be done mostly through two ways. One is getting an amyloid PET. It's a special type of scan that can visualize the amyloid protein in the brain. If the amyloid protein is present, it's highly likelihood that any cognitive symptom is related to that buildup of the protein, and that's one of the features of Alzheimer's disease. The other way of confirming the diagnosis is doing a lumbar puncture study or a spinal tap, taking a little sample of fluid from the back and send it to analyze. And that also measures levels of amyloid and another protein called tau, which is also implicated in Alzheimer's disease. When there is a signature in the fluid that shows low amyloid in the fluid and high tau in the fluid, that is diagnostic of Alzheimer's disease, and that will be another way to confirm. So once people is eligible on that side, then there are other procedures that will be required. For example, making sure that there are no contraindications or any reason for people to have an excessive risk when getting the drug. For example, there might be some medications like blood thinners that might need to be used with care, with a lot of care. So in some cases, they might not be possible or not be compatible with these anti-amyloid drugs. And then it will be very important for people to also get a gene test for ApoE. ApoE is a risk factor for Alzheimer's disease, but in the context of a drug, it modulates, depending on your genetic makeup for that particular gene, it modulates your risk of side effects. That is important. It has been important, for example, to establish how quickly you increase the dose of certain some of these medications, but it can also be informative for people to decide whether they are willing to take the risk of getting the drug. So it's going to be based on expert consensus. The gene test is going to be important. So the gene test, the amyloid PET or the spinal tap, and then a cognitive evaluation to set a baseline. And then people will come to the infusion center twice a month, every 15 days to get the infusion through the vein. And at the beginning, maybe every month for the first 3 to 6 months, depending on the protocol, we might need to do a brain MRI. So these are involved. It's going to be a very involved sort of therapy. Almost like we are thinking when we designed how we're going to do this, it's almost like the way, as intense as how it's done with cancer treatment, chemotherapy. Very involved, very hands-on, and people will spend a lot of time in the clinic. This is the best way we have. Potentially, we are looking at alternate forms for the future. For example, we are looking at sending people home with an auto-injector that they could give their dose through the belly, at home every day, for example, or every week. Those are things that we're still investigating, and that's why clinical trials need to continue. But for the time being, we're looking at twice a month infusions coming to the infusion center, specialized centers, which that creates a problem on its own of accessibility, right? People might not have access to an infusion center, and we are also working on that part, trying to make the drugs as accessible as possible to everybody.
Do you know how soon something like this could potentially get FDA approved and become accessible?
I think the main barrier for approval has been the efficacy data. If the efficacy data is solid, which I think it's the case now, then you start looking at all the other aspects, right? What is the feasibility? What is the benefit for the medical system, right? It may be an expensive drug, but maybe you can save on other costs if you prevent people from going into, dementia. So all those things need to be factored in, and that is what usually, obviously, the safety, right? Putting everything on a risk-benefit ratio, all of those things are considered by the panels that approve the drug, and we all expect that particular drug, Donanemab, will be approved. Now, I have to mention, a similar drug in the same family has already been approved, which is lecanemab. Lecanemab was studied through the same pipeline, same similar profile, same type of results, same type of efficacy and safety, and was already granted approval. And we are working hard to make that medication available. And then there was another drug, Aduhelm or aducanumab, who got conditional approval even earlier with more controversy. But in my view, the three drugs have a similar profile. So it's exciting that we're going to have more options. Hopefully, the competition will bring lower the price to the benefit of people, of patients. And one of the big things for access has been who's going to pay for it. If people are expected to pay out of pocket, it's not going to be accessible to a lot of people. But if Medicare wants to kick in or private insurance wants to cover, then that's a different scenario, and that could potentially bring more benefit. And we expect that Medicare will also cover for this cost. We've been making progress in the last few years in terms of how Medicare sees these drugs, but I think we're getting to the point that we will have all the elements in place to be able to use them safely. And to use them to distribute the benefit in a fair way, right? One thing that is important to consider is, when we have a medical development, in theory, the benefit of that new development, that new technology or new treatment, is distributed equally among all members of society, right? We know, for example, that minoritized groups, Hispanics, Black people, people with low socioeconomic status, they might historically not receive the benefits in the same way. But it's possible that a new medical medication or medical technology emerges and we still don't deploy it fairly to everybody. People, Hispanic, low socioeconomic status, they might not have access to a neurologist or a test to diagnose dementia, or they might live very far away from an infusion center, and that benefit is not going to touch them. So we have to be very mindful of how we deploy the drugs to make the benefit fair for everybody. For example, in California, Hispanics may be 35% to 40%, and the clinical trials enroll up to maybe 10% of people are Hispanic. So there's a little bit of disparity even there, even at the point of generating the efficacy and safety data. So those are problems that we need to continue lobbying for, improving in new studies, and at the time of deployment, we have to be very mindful. We have to be very, very purposeful in how we provide access for the drugs. That's also very important.
Is there anything else that you'd like to go ahead and add that you'd like everybody else to know, or anything that's important?
Well, I want to reiterate the invitation to people who want to help us create new drugs or discover new drugs. This is not a medical endeavor only. Alzheimer's disease and dementia is not just a public health issue. It's a social problem, and it will touch all of us. And we cannot expect that the medical community will do it alone. We need to partner with society. Just as we solved every social conflict in the past, we have to involve the community and policymakers and industry and the medical community to bring solutions. So it's only through this partnership that we can make progress. So if we have new drugs, it's not just because a company paid for it or the doctors came up with it. Yeah, the new drug is because people participated. People with Alzheimer's disease or people with dementia and their families, everyone supported this endeavor. So the only way forward is to continue doing this, make it even more efficient, refine it, improve it. And the example of AHEAD, the study AHEAD study.org, if people want to take a look at that. That's the sort of partnership that we need to do with the community, and this is a problem that we all need to be involved in, and it's our generational problem. Maybe the problem for the generation before us was cancer, and for our grandparents maybe it was heart attacks and tuberculosis. But for our generation, what we are obligated, we have the responsibility to tackle the problem of dementia. That's the way I see it. So thank you again for letting me share these ideas, and I hope these thoughts help some people out there. I'm available to answer questions, and we are always willing to engage with the public. So if that comes up, I think this is something that we're willing to do. So thank you again.
Dr. Rojas, thank you so much. It was truly a pleasure.